Universidad Católica de Santiago de Guayaquil. Dapagliflozin and renal outcomes in type 2 diabetes and nephropathy. English Medical, name Adrian Lopez, Parallel D, period A, 2019. Facultad de Ciencias Médicas. Dapagliflozin and renal outcomes in type 2 diabetes and nephropathy. Introduction. Sodium glucose cotransport 2 SGLT inhibitors have shown beneficial effects on renal outcomes made in patients with established atherosclerotic cardiovascular disease. Here we report analysis of renal outcomes with the SGLT2 inhibitor dapagliflozin in declared TIMI 58 cardiovascular outcomes trial, which includes patients with type 2 diabetes both with and without established atherosclerotic cardiovascular disease and monthly with preserved renal function.
Now let's move on to diabetes. There were the DECLARE results. How do they fit in?
DECLARE was an interesting study. It looked at an SGLT2, a drug that in part increases loss of glucose in your urine. We think about these drugs to alter glucose levels, controlling them better, but in DECLARE we found that in fact these could alter the one's likelihood of developing either heart failure or alternatively developing renal insufficiency, kidney problems. The drug was not effective in preventing development of atherosclerotic disease or coronary disease. But for patients, my perspective is, if you tell a patient, I can control your sugars better for a diabetic patient, but I can also reduce your likelihood of developing heart failure or kidney disease, two of the things you worry most about, that's a win.
So does this mean we should also be thinking about treating heart failure or preventing heart failure and renal disease in type 2 diabetics?
Yeah, I think it's exciting. We have thought traditionally about diseases in one box or in one dimension. We have drugs that lower glucose, and we thought about them as diabetic treatments. The realities are these drugs have multiple effects, as we're seeing in DECLARE, reducing one's likelihood of developing heart failure, improving one's kidney function as a function of time, or not preventing worsening of kidney function. So I think we're thinking about now these drugs, how we're treating a whole diabetic patient. Not only their control of their glucose, but looking at how it might affect their heart as well as their kidneys.
Great.
Application in medicine. Patient with type 2 diabetes with either established atherosclerotic cardiovascular disease or multiple risk factors and creatinine clearance of at least 60 millimeters per minute were randomly assigned to 10 mg dapagliflozin or placebo once daily.
There's lots of additional research being done in this area. I think it's a very exciting area presently. Certainly, we will have more information from this study in terms of specific subgroups and other types of outcomes. There'll be a lot more information about the kidney disease coming forward soon. There will be information about biomarkers. We start to wonder whether we might be able to identify specific groups of patients which benefit more. The other interesting thing is that because of the results of these types of trials over the past few years with successful cardiovascular benefit with the SGLT2 inhibitors, there is a lot of ongoing research trying to even broaden out the population potentially further. So patients who are being treated for heart failure, patients with chronic kidney disease, and even in some patients who don't have diabetes, that the concept is whether these drugs may be beneficial independent of their effects on blood sugar. So really a lot of exciting research going on with these classes of agents. In my mind, really what's developed over the past couple of years is different than the way we've treated diabetes for decades. That we used to really focus completely on blood sugar levels, what the hemoglobin A1C was, did you get it to goal, and it didn't so much matter how you got there. But with the trials of SGLT2 inhibitors and another class of drugs called GLP-1 receptor antagonists, we're now seeing that there are drugs that actually have significant benefits. So I think we're moving away from a how much do you lower to how do you lower, which, using the appropriate agents that have these types of outcomes. So I think we're moving into a time where we're going to be really switching the paradigm of how we manage our patients with diabetes and cardiovascular risk.
Pros and cons. Pros: reduce kidney disease. Cons: death, myocardial infarction, stroke, hospitalization for heart failure.
So I think probably the major strengths were that this was a large trial. So more than 17,000 patients were enrolled in the study. So it gives us fairly definitive answers, right? We're not concerned that we were underpowered, there was a trend toward this or a trend toward that we have fairly definitive answers. I think another strength is the population of patients in this trial is more representative of a population that might be seen in a general practitioner's office. You certainly see lots of patients with diabetes. Only a portion of those patients have had a heart attack or a stroke previously. Many more of them are in this primary prevention group. And the population that was enrolled in this trial just had to have one additional risk factor. So had to have hypertension, had to be a smoker, had to have elevated lipids. So I think that this is a trial that reflects the population that people are seeing in clinical practice. I think that all clinical trials are have some limitations, and it's not quite the real world, right? We end up having many more interactions with the patients than they do in general clinical practice. So sometimes the compliance with medications and things like that may be better. In this trial, we also did what's called a run-in period, where patients had to take a placebo for a month. They didn't know it was placebo. They thought they were taking a study medication. But if patients didn't comply with that, then they weren't enrolled. So I think that in some senses, this is an idealized experiment, right, that the patients were more likely to take the study medication, were more likely to be compliant. Certainly in order to have benefits, you need to be, on the therapies. So, I think my biggest limitation for this would be that that the compliance was probably better than you might expect in clinical practice.
Issues in Ecuador. As reported, the cardinal secondary composite outcome was significantly reduced with dapagliflozin versus placebo as a rate of 0.76. We identified a 46% reduction in sustained declining FGFR by at least 40% to less than 60 millimeters per minute per 1.73 meters. Hazard ratio 0.54. The risk of end-stage renal disease or renal death was lower in the dapagliflozin group than in the placebo group. There are a decrease in FGFR was larger in the dapagliflozin group than in placebo group. In conclusion, dapagliflozin seemed to prevent and reduce progression of kidney disease compared with placebo in this large and diverse population of patients with type 2 diabetes and without established arteriosclerotic cardiovascular disease, most of whom has preserved renal function.
Hi, my name is Steve Wiviat. I'm a cardiologist at Brigham and Women's Hospital in Boston and a senior investigator with the TIMI study group. I'm here at the American Heart Association Scientific Sessions in Chicago. We will be presenting the primary results of the DECLARE TIMI 58 trial. DECLARE is a randomized trial of an SGLT2 inhibitor, dapagliflozin, in patients with diabetes and established cardiovascular disease or patients at risk for cardiovascular disease, so both primary and secondary prevention. This trial was done because patients with diabetes are at high risk for both the development of atherosclerotic cardiovascular disease and heart failure, and also complications of those illnesses when they occur. So this study involved 17,160 patients. About 10,000 of those patients were primary prevention. About 7,000 of those patients were secondary prevention. They were randomized to 10 milligrams of dapagliflozin or placebo and followed for 4.2 years. We had a primary safety outcome, which was to demonstrate that it did not increase the risk of major adverse cardiovascular outcomes. And we had co-primary efficacy endpoints, cardiovascular death and hospitalization for heart failure, and also MACE for efficacy. What we saw was that the dapagliflozin reduced hemoglobin A1C. It also reduced body weight by about 2 kilograms and reduced blood pressure. This ultimately translated to a reduction of the primary endpoint of cardiovascular death and hospitalization for heart failure by about 17%. This was highly statistically significant and was driven by a significant reduction of about 27% in the hospitalization for heart failure component. From the MACE standpoint, we demonstrated that the drug was safe. It did not increase major adverse cardiovascular events, but we did not see a statistically significant reduction in major adverse cardiovascular events either. With only one of the two co-primary endpoints being favorable, the other outcomes would be considered hypothesis generating. But one of the other key outcomes was we saw robust reductions in renal composite endpoints, suggesting a delay in the progression of renal disease. So the key takeaway messages from this trial were that dapagliflozin was safe. It did not seem to increase adverse events that there was previously concern about, like strokes or amputations, and it was effective particularly in reducing heart failure events. This extends the benefit of this class of agents from the secondary prevention realm, patients already with established cardiovascular disease, to patients also in primary prevention, those at risk, which is a much bigger population of patients. We also tried to put these data in the context of the current understanding of SGLT2 inhibitors. We did a meta-analysis of the 3 large outcomes trials with SGLT2 inhibitors, and we began to see some fairly consistent results. And with that, we saw that there was really a modest reduction in major adverse cardiovascular events, ischemic MACE, which seems to be confined to those patients in secondary prevention. But we did see that there were robust reductions in heart failure-related and kidney-related events that did not depend on whether the patient was a primary or secondary prevention patient, whether the patient had pre-existing heart failure or not, or other baseline features. So overall, from a clinical standpoint, there is emerging and strengthening data about this class of drugs, these SGLT2 inhibitors, that seem to be fairly potent in patients with diabetes and risk factors, or patients with diabetes and established disease, in preventing important cardiovascular events. So it seems that we as cardiologists and our diabetes colleagues should be thinking about the use of these drugs earlier in disease with the potential to prevent important outcomes. Thank you.
Thank you.